Hello, everyone, and welcome back to our next session. It will be presented by Dr. Georges Dabar. Dr. Georges Dabar is a medical director at Hôtel Dieu de France. He is a pulmonary and critical care in Hôtel Dieu de France. He is assistant professor in St. Joseph University, American Board of Internal Medicine, American Board of Pulmonary Medicine, and American Board of Critical Care Medicine. Welcome with me, Dr. Georges Dabar. He is going to talk about PAH-CTD, early detection and treatment, make outcome difference. Welcome, Dr. Dabar, and the floor is yours.
Good morning, everyone. It's my pleasure today to discuss pulmonary arterial hypertension and connective tissue disease. And what we'll be insisting on today is the early detection and the effect on the outcome of the early detection and early treatment. Pulmonary arterial hypertension can be as deadly as most severe cancer if you leave it untreated. This is data taken from the REVEAL registry looking at the different functional class of pulmonary hypertension. Looking at them as functional class 4, 3, 2, and 1, you can see that functional class 4 can be as deadly almost as lung cancer and ovarian cancer, while functional class 1 and 2, as far as 5-year mortality, it could be as deadly as non-Hodgkin lymphoma and breast cancer. So keep in mind that this disease, pulmonary arterial hypertension, can be as bad as cancer as far as mortality. Detecting it will lead to improved in mortality. While when you diagnose cancer at stage 3 and 4, you have its attributed mortality according to stage 3 and 4, even if you treat and the stages at the stage changed. While in the pulmonary hypertension, when you step down the functional class, or when the functional class drop by 2 points or by 1 point, the outcome at 5 years is much better. This is why it's so important to screen for pulmonary hypertension in connective tissue disease. While pulmonary hypertension is defined by mean pulmonary arterial pressure of more than 20 millimeter of mercury, confirmed on right heart catheterization. To be more precise, in pulmonary arterial hypertension with the right heart catheterization, so the pulmonary wedge pressure has to be less than 15 millimeter of mercury. The pulmonary vascular resistance have to be above 3 Woods, and in absence of pulmonary hypertension due to left heart disease, chronic lung disease, or venous thromboembolism. One more caveat you have to be careful with is the following: that many patients with pulmonary arterial hypertension have more than one condition contributing to their total pulmonary hypertension burden. So what you need to do is look for disproportionate pulmonary hypertensive response in group 2 and 3 pulmonary hypertension, mainly in chronic pulmonary disease and heart disease. And if the numbers are much higher than what you expect, and the patient has an underlying, for example, collagen vascular disease, well, you need to keep in mind that part of the pulmonary hypertension is coming from the collagen disease. And also we need to distinguish, especially in the elderly, pulmonary arterial hypertension from pulmonary hypertension due to heart failure with preserved ejection fraction, something that you will find in elderly patient. So let's go back to the pulmonary hypertension diagnosis. Typically, it is delayed over 2 years to get to the right diagnosis. The severity of disease, the majority of the patient at diagnosis are picked up when they are late in the disease, especially the group 2 and the group 4. And this delay in diagnosis lead to delay in therapy, and consequently with a poor effect on 5-year survival and on morbidity and on outcome overall. So this is important to keep in mind that the earlier you detect, the more effect you will have on outcome, especially that you will treat earlier the patient. Let's look at the group of pulmonary arterial hypertension. Usually you have 1/3 related to idiopathic pulmonary hypertension, 1/3 related to congenital heart disease, and around 25% due to connective tissue disease, according to where you live and which country you live. There is a small part related to portopulmonary hypertension that's included in the pulmonary arterial hypertension, and some minority of patients that are not really have a well-identified etiology. Historically, the survival in pulmonary hypertension related to collagen disease or connective tissue disease has been reported to be worse than idiopathic pulmonary hypertension, and this is looking at time for diagnosis in the review registry for 7 years, and you can see that in yellow, the pulmonary hypertension patient with connective tissue disease has there is a lower survival compared to the idiotic pulmonary arterial hypertension. So this is another incentive to screen for the disease early, especially that we know now that treating early would affect survival. And talking about screening, you can see, you can look at this study, and where people were screened, divide the group in two, a group that was screened and a group that was not screened for pulmonary arterial hypertension. And we can see that when you screen, you pick up patient in lower functional class, functional class 1 and 2, while when you don't screen, you pick them in a later class, class 3, functional class 3 and 4. And that has, as you know, an impact on 5-year survival and on morbidities and hospital admission. So screening is very important. In scleroderma patient, it is really recommended, and this is a recommendation coming from different body. This is the World Symposium on Pulmonary Hypertension that supports recommendation for annual screening for pulmonary arterial hypertension in patients with scleroderma. And this is the guidelines from ESC and ERS, European Society of Cardiology and European Respiratory Society, where for them it's a class 1 with a level C evidence where resting echo is recommended as a screening test in the asymptomatic patient with scleroderma, followed by annual screening with echo with diffusion capacity and biomarkers. So it's a class 1 level C recommendation. And the recommendation for screening and detection for pulmonary arterial hypertension and connective tissue disease. Each patient with scleroderma should be screened annually for pulmonary arterial hypertension due to the high prevalence of pulmonary arterial hypertension and scleroderma. And one of the tools, or the best tool to look for pulmonary arterial hypertension in scleroderma patient is the DETECT tool. It's an application that you could use on your smartphone, and this application compute the ratio of FVC over diffusion capacity in percentage, the anti-centromere antibodies, telangiectazy, NT-proBNP, right axis deviation on the EKG, and the uric acid level. You put in this in your smartphone, you get the score. If it's that's more than 300, then you go to echo, and on the echo, you look for the right atrium size and the TR, tricuspid regurgitation velocity. And if the score is more than 35, you go to right heart catheterization. And this is how the tool look like. So you compute the different numbers that you have on your pulmonary function test, on the physical exam, the anti-centromere antibody, the NT-proBNP, the uric acid, the EKG, if there is a right or axis deviation or no. And according to the score, let's say you get 350 on the score, then you go down and you do the echo, and on the echo, they measure the right atrium size and TR velocity. And if you get a score of more than 35, and doing a right heart catheterization. All the guidelines support the use of the DETECT as a screening tool in a patient with scleroderma. So annual screening of pulmonary hypertension in patients with scleroderma or scleroderma spectrum of disease with uncorrected diffusion capacity of less than 80% of predicted should be considered. Appropriate screening tools include the DETECT that we looked at, the 2015 recommendation for transthoracic echo or an FEC over diffusion capacity ratio of more than 1.6 or a twofold, and a twofold upper limit normal of NT pro BNP. All those should push you to do a transthoracic echo. As far as the ESC-RS guidelines, it's a class 2B recommendation with a level B recommendation. So initial screening should be using the stepwise DETECT algorithm, and it may be considered in the adult with a systemic sclerosis patient with 3 years of disease and a diffusion capacity of less than 60%. So if the patient have those conditions, it's a class 2 evidence to do echo. Recommendation for screening and detection of pulmonary arterial hypertension. So the initial screening evaluation, you do the DETECT algorithm, and accordingly you get the echo or the right side CAT. And if there is criteria, so you go to the right side CAT if it's more than 35, as we said. So the DETECT tool is here to help you. You can put it on your smartphone, you plug in the numbers. The variable that you would need is an FVC, diffusion capacity, NT-proBNP, uric acid, your physical exam, and you can get your numbers and decide if you want to go to the echo, and according to the echo, you decide if you want to go to the right heart catheterization. It's important to know that more than 40% of the early diagnosed patient with scleroderma and pulmonary hypertension, they have disease progression during follow-up. So even if you detect them early, doesn't mean they're going to be stable, they can progress. 40% of them can progress or can have events. Excuse me. They can have functional class worsening, they can be functional class 2 and go to functional class 3. They can be hospitalized for pulmonary hypertension, or they can have sudden death or mortality. And this is looking at around 55 patient, 57 patient, and when they looked at them in the DETECT cohort, some of them were at functional class 1, that was the minority. The bulk of them were functional class 2 and 3, 36% and 42%. So most patients had mild or no pulmonary arterial hypertension diagnosis. This is important. So most of them had mild or no symptoms at diagnosis. This is why you need to screen. So some of them may not have symptoms. Patients with early pulmonary arterial hypertension have a meaningful rate of disease progression requiring careful follow-up. Around 40% of them had disease progression. And given that the pulmonary arterial hypertension is a high-risk complication in scleroderma, and therapy should be initiated early and escalated to prevent this progression and to improve outcome. The other thing is that a regular multi-parameter risk assessment should be carried out in patient. The number of low-risk criteria at baseline and the first follow-up for patient with pulmonary arterial hypertension is associated with better long-term outcomes. So the risk assessment is very important, and you will look at the different parameters for the risk assessment. What's important to know is that when you have when you are low on your risk assessment, the likelihood to stay low is stay there at follow-up when you do a 5-year follow-up. So you almost have the same rate. If you look at the left and on the right, you have the same rate of patients staying in the green line, which is the very low risk or zero risk of severity criteria, and the survival is good. And the more severe you are, the worse is the survival. Screening improve long-term outcome in scleroderma. So this is looking at routine practice and then screening group, looking at two cohort, and the patient who were screened had better 8-year survival compared to the patient that were not screened, because they are, as we said earlier, picked up at the worst functional class, like 3 and 4, where you have more morbidity and mortality. The goal of the treatment is to achieve and maintain a low risk status, so being in that first column. And those are the criteria for low risk, intermediate risk, and high risk. And it is important that the updated guidelines for the treatment look at those of those goals and of those risk factors: low risk, intermediate risk, and high risk. So the guidelines recommend regular multi-parameter risk assessment, both at diagnosis and at follow-up. And what are those parameters? So clinical signs of right heart failure, if they are present or absent, progression of symptoms, yes, no, or no, and how fast. Syncope is present or no. The functional class, the 6-minute walking test being more than 440 meters or less. The cardiopulmonary exercise testing with the peak VO2, more than 15, 10 to 15 less than 11 to 15 less than 11. The NT-proBNP if it's low or high. Echocardiography with the right atrium size. And the hemodynamics on the right heart cath with the right arterial pressure, the cardiac index, and the SVO2. And you can end up being low risk, intermediate risk, or high risk. And this is risk estimate mortality at 1 year, less than 5%, intermediate risk 5 to 10%, and more than 10% mortality in the high risk patient. And the goal is to move from the red to the yellow to the green, or keep the patient in the green if he's on the green. And this is important because the risk assessment plays a prominent role in the newly published treatment algorithm for pulmonary hypertension. So if we follow a little bit the algorithm, the PAH confirmed by an expert center, well, what you do is if you are treating naive, you do general support, make sure that there is no agent that's making your hypertension worse, supportive treatment, and do the acute vasoreactivity test for this group of patients. If the patient is vasoreactive, then he will go on to calcium channel blocker. If the patient is not vasoreactive, then you have to see, according to the previous table, if he is a low risk, intermediate risk, or high risk. And if the patient is low or intermediate risk, we have to go with initial oral combination. We'll go over this in a minute. There are very small number of patients that are still on monotherapy. There is a residual role for this initial monotherapy. If the patient is high risk, you may go into initial combination, including prostacyclin antagonist or triple therapy, and you consider referral for lung transplantation. You have to reassess after 3 to 6 months. If already, and then you classify the risk of the patient again. Low risk, you do the follow-up. Intermediate or high risk, you escalate, or you go to triple therapy if you're not on it already. And you are assessed at 3 to 6 months, and definitely you consider the patient for lung transplant. So let's go to the pharmacological treatment. The pharmacological treatment considers 3 pathologic pathways: the endothelial pathway, the nitric oxide pathway, and the prostacyclin pathway. And the endothelial pathway will look at endothelium, and then we use endothelium antagonist, and then the family of medication used is ambrisentan, bosentan, and macitentan. The nitric oxide pathway will block will actually accelerate the nitric oxide pathway, vasodilation, and antiperforation. And you have the SGC, the guanylate cyclase stimulator, or the PDE5 inhibitor. Basically, those are 2 types of medication. In the prostacyclin pathway, you have the prostacyclin receptor that's acted on, and you can use the PGI2 analogs or the non-prostaglandin receptor antagonist. With the analogs, we have the epoprosterol, the treprostinil, the iloprost, and veraprost, and the receptor agonist, you have the Selexipag, and the role is the vasodilation and anti-proliferation of the smooth muscles for this mechanism of action of the 3 pathways. And we'll go over the trial of the combination of those type of medication. Well, let's start with the meta-analysis of combination therapy versus monotherapy in patients with pulmonary arterial hypertension and connective tissue disease. While the use of the combination therapy significantly reduced the risk of clinical worsening event by 27% compared to monotherapy. This is by the compilation of 4 major studies for pulmonary hypertension where combination therapy was used versus monotherapy. And you have the Ambition, Compass-2, Griffin, and Seraphine study. And the result of the meta-analysis is in favor of 27% reduction in any event compared to for the combination therapy compared to the monotherapy. And this is very important concept where this is why there is little roles for monotherapy at initiation of treatment of pulmonary arterial hypertension. And this is looking at the beneficial effect of double combination therapy on the long-term outcome compared with monotherapy. Looking at the Seraphine and the Ambition. The Seraphine, what was double combination therapy versus therapy, the macitentan significantly reduced the risk of mortality and morbidity event in patients on a background pulmonary arterial hypertension. This is looking basically at 3 years of treatment and the difference in survival. You have a reduction in improvement in 38% in risk reduction at 3 years and combination therapy versus monotherapy. Again, this is the Ambition trial, looking at over 3 years, about 170 weeks of ambrisentan and tadalafil combination therapy that reduce significantly the risk of clinical failure compared to monotherapy. Basically, this is really important. So combination therapy is much better than monotherapy. And this is basically looking at the echography signs. And this is the repair study with the treatment. You can see the right ventricular stroke volume improvement, a significant improvement by 15 milliliter. And you can see on the echo, you have a better right ventricle size, less distended. There is no septal paradoxical movement on the left ventricle. You have a better size of the left ventricle. Now we look at the OPUS study, which is pulmonary arterial hypertension and scleroderma, and idiopathic pulmonary hypertension had similar survival at 1 year after initiation of macitentan. And we look at the study that 1/3 of the patients were on monotherapy and a small percentage was on triple therapy, and then the majority was on double therapy. So on survival, you have good results in idiopathic pulmonary hypertension and pulmonary arterial hypertension secondary to scleroderma. Don't forget that one of the first slides we showed was saying that the patient with IPH had a better prognosis at 5 years compared to PH secondary to scleroderma when historically, not with the new therapies or the combination therapy. So treatment should be intensified if patient have an intermediate or high risk profile. So if the patient has the findings they have symptoms, they are in bad functional class, they have high BNP, they have findings on echo that are not that was right with large right atrial site, right axis deviation, etc. They are a patient at intermediate or high risk. Now we have to step up with the therapy, and we go back to the algorithm. And again, you do the acute vasoreactivity, responder calcium channel blocker. Non-responder, you have to go into the risk, and then you go low, intermediate, or high risk. And if you are intermediate or low, initial oral combination, or you are high risk, initial combination, including IV prostacyclin antagonist, and you refer to transplant. And you reassess at 3 to 6 months, intermediate or high risk, triple sequential combination. And this is very important. And triple sequential combination when you remain at intermediate or high risk, and you are assessed at 3 to 6 months, and you maximize your medical therapy, and you list for lung transplant if you're not improved. There is a limited historical use of triple combination therapy in clinical practice. You can see here 4% of triple therapy in Europe, 7% in the United States, and in China 4%. Maybe in Japan there are much higher use. This is historic. The reason why, because prostacyclin was being administered or by intravenous pump, and this is cumbersome for the patient, or inhaled by inhalation, and you have to use it many times per day. And this is why triple therapy was not really popular. Till we have the Selexipag, which provide the opportunity to target the prostacyclin pathway with an oral treatment. Okay, as we said, we had the inhaled treprostinil and the iloprost. We have the epoprostenol intravenous and the subcutaneous treprostinil. So they were really cumbersome to use, sometimes frequently or by continuous pump. And now we have the oral Selexipag, which make the prostacyclin therapy much more attractive. Not to tell you that the mechanism of action is vasodilation and anti-proliferation. And it came even in the guidelines as a sequential double or triple combination therapy with Selexipag at the first sign of our intermediate risk, and it comes in according to what functional class you are, a functional class 2, 3, or 4. It could be a 1B, 1 with evidence B recommendation, so in class 2 and 3, and it could be a 2A recommendation in class 4 with a C level of evidence. And this is exactly almost the same algorithm as we had before. So if you are non-reactive, you are low intermediate risk, WHO functional class 2 or 3, initial oral combination. This is a minority. This is really historical initial monotherapy. And then you have, if you have inadequate response, you go to triple therapy. If you are class 4 initially, you go to initial combination therapy, but here including the IV prostacyclin, while he initially started double therapy, and you go to a sequential triple therapy if you have no improvement. Let's go over the Selexipag and the Gryphon study. So the primary endpoint was the time to first mortality and morbidity, the composite index, basically at 3 years or at 36 months. And you see a 40% risk reduction using Selexipag compared to placebo. So this is very important. And when we look at the patient according to their underlying disease, also looking at this composite endpoint, relating at the composite endpoint of morbidity and mortality, the effect of Selexipag compared to placebo and whatever medication the patient were on for pulmonary arterial hypertension. And you can see that in scleroderma, the benefit is a 44 reduction in relative risk reduction. And in lupus, it's a 34% risk reduction at 30 months. Now, it delays the progression as a triple therapy compared to combination therapy. This is patient already in the background taking ERA and PDE 5A therapy, and looking at Selexipag being added to them compared to placebo. And you can see there is also risk reduction of 37% over PDE5 inhibitor and endothelin receptor antagonist inhibitor, in addition to Selexipag compared to placebo. So it has an effect on the top of the two other vasodilator. And also, according to which functional class you have an effect also, Selexipag delayed disease progression as triple therapy combination in functional class 2 and class 3 compared to the two medication. And the effect is higher the lower the functional class. So a 64 risk reduction in functional class 2 and a 26% risk reduction in functional class 3. It's important to look at that. This is over 30 months. And also it has a more pronounced treatment effect if you started earlier compared to if you start later. This is if you started in the first 6 months of diagnosis compared to if you started after 6 months of diagnosis. So this is why it's very important to assess the patient frequently and to go to triple therapy if needed quickly. And you have a 55 risk reduction if you start in the first 6 months compared to 30% risk reduction if you go in the following 6 months. So delaying therapy would really doesn't really serve you well. Again, looking at Selexipag, delaying the disease progression, looking at a patient with low, medium, and high level of NT-proBNP. And this is really from the Griffon, and I want you to focus on the green and gray. You have the complete lines, green and gray, dotted lines, green and gray, and intermittent lines, green and gray. And you can see that there is really a difference comparing them. And then we go at the table. And you go into the subgroup of patient with NT-BNP, with low NT-BNP group, medium and high, and you can see that is compared to, this is at baseline and the time-dependent analysis. And you can see that at baseline, there is a significant reduction. The effect is higher in the low and medium intermediate group compared to the high intermediate group. So in a time-dependent analysis, also the risk reduction of multimodality in pulmonary arterial hypertension with Selexipag was more pronounced also in the low pro-BNP category, basically looking at those two lines. This is over time also. Now, triple oral combination therapy with Selexipag is improving or maintaining the risk profile in a real-world setting. Looking at patients in the US and Germany, just a small portion of them worsened while the majority remained in their in a good, in an acceptable risk profile. So the majority of patients maintained or improved the risk profile following triple therapy combination regimen with Selexipag. Also, initiation of triple oral combination therapy with Selexipag is effective at maintaining and improving even the functional class in a real-world setting. This is the green, the group that improved. In the light blue, the group that maintained. A very small group got worse. So the lesson to learn from this presentation is one, all scleroderma patients should be screened for pulmonary arterial hypertension annually. Early initiation of therapy has been shown to improve long-term outcome, and all current treatments guideline and recommendation, including those from the recent WSPH, endorse the use of the DETECT, which is the tool that you can put on your smartphone and compute in if you need to pursue cardiac echo and right heart catheterization. This is from the screening point of view. As soon as you have pulmonary hypertension, arterial hypertension, the way we defined it, and you classify your patient according to symptoms as class 1, WHO 1, 2, 3, and 4. And then you put the risk, which has low risk, intermediate risk, or high risk, and you initiate therapy. So upfront or early sequential combination therapy has improved outcome for pulmonary arterial hypertension secondary to connective tissue disease patients, usually considered difficult to treat, and historically this population had a higher mortality compared to IPH. Regular multi-parameter risk assessment is essential to ensure escalation of the therapy at the right time, and attaining and maintaining a low risk profile is the essential goal of therapy to have the best outcome. Thank you.